Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more. In today's podcast, we have the opportunity of visiting with Dr. Amy Moultrie. She is the president of the Minnesota Academy of Eye Physicians and Surgeons, and she joins us today to talk about leading a state ophthalmology society and her role as an ophthalmic pathologist.
Dr. Amy Moultrie is a board-certified comprehensive ophthalmologist and ophthalmic pathologist, as well as current president of the Minnesota Academy of Eye Physicians and Surgeons. She's an associate professor with a dual appointment in the Department of Ophthalmology and Visual Neurosciences and the Department of Laboratory Medicine and Pathology at the University of Minnesota. She practices comprehensive ophthalmology at the Southdale Eye Clinic in Edina, Minnesota, and serves our veterans at the Twin City VA Medical Center, where she teaches cataract surgery to residents from the University of Minnesota and Mayo Clinic. Dr. Moultrie was recognized in the Top Doctor issue of Minneapolis-St. Paul magazine as a rising star for 3 consecutive years. She's been listed as a Castle Connolly Top Doc every year since 2020. She's had an achievement award by the AAO for her commitment to advancing the profession and positively impacting patient health. She was voted Best Teaching Faculty and the Surgical Teacher of the Year by the ophthalmology residents at the University of Minnesota. We're so excited to have her. Welcome, Dr. Moultrie.
Thank you guys so much for having me. I'm so excited to be here and to sit down and talk with the two of you.
I've always appreciated you, Amy, as a colleague, as a friend, because of the different hats you juggle. And today we get to talk about not just ophthalmology things, but pathology, which is one of those niches in ophthalmology where you go, I wish I remembered what that cellular makeup was about. And then that's more on a microscopic scale, yes. But then on a macro scale, the wonderful hat you've shepherded this year at our Minnesota Academy. So before we get into those things, share with us your career path. What has led you to being not just an ophthalmologist, but also an ophthalmic pathologist, and your roles as you currently hold?
Yeah, and I think from what happens to many people, I sort of feel like I fell into it. I was a medical student at the University of Wisconsin, and one of my mentors there was their ophthalmic pathologist. And when I was, getting advice about residency and about the match, she, recommended I do away rotations. So I did an away rotation at the University of Iowa, and there weren't any spots in their the clinical rotation. So the only spot they had for an away student was in ophthalmic pathology. And so that was really my first introduction to eye pathology. And I really clicked with my mentor there, who was their ophthalmic pathologist, Nazreen Syed, and really enjoyed that experience. And then I think it was really that experience that led to me matching at the University of Iowa, which is where I did residency, and continued then to have really a great pathology experience along with, enjoying all the rest of my training, and stayed there to do my eye pathology fellowship. So it's really the connections that you make with people along the way. And I always say there's very little in medicine that I felt like came really naturally to me. You just have to you work really hard and you study and you gain the knowledge. But the pathology, I sort of felt like I could look at it and recognize it and know it. And it wasn't, you obviously still study and learn, but it's that pattern recognition. And that was really something that I could do and do well.
I love that. When you know it, you know it.
Mm-hmm.
But it is interesting. I think it's unique that you have both a comprehensive practice and an ophthalmic pathology practice, because most people are one or the other. So how do you balance being a surgeon and a pathologist? Because I think that's pretty uncommon.
Yeah, it's one of the things I've really loved about how my career has developed. I enjoy that variety a lot. So I'm about 70% comprehensive ophthalmology. Mm-hmm. So I'm in clinic 3 days a week, and I have a half day of surgery a week. And then my other 3 half days are pathology. And it means I get to do something a little bit different almost every day. And my pathology days are really enjoyable because the pathology slides don't complain if I'm behind.
Yeah.
So
Yeah.
I really like, it's just a different way of doing medicine. It's a different way of helping patients. And pathology is a ton of fun because it's collegial in a little bit of a different way. So it's very easy to share a case and to share a slide. So you spend a lot of time in pathology, finding other people to show things to and talking about it and getting their perspective. And I work a lot with our neuropathologist. His name is Garrett Fitzpatrick, and he's fabulous. And he just comes at things from a different perspective because he's come from the pathology direction, and I've come
Right.
from the ophthalmology direction.
Well, that segues perfectly. I wanted to ask you this question because I'm always thinking about things from the kind of young ophthalmologist standpoint. So when you're thinking about career path, is there a benefit, do you think, from coming at it from the ophthalmology side, like doing an ophtho residency and then doing pathology versus a pathology training into ophthalmic path? Are there advantages and disadvantages of the different paths?
I think it's really just about kind of finding that area of interest regardless of which direction you come from. There's very few places where there's really enough volume and need to do full-time eye pathology.
Sure.
So whether you come from pathology or from ophthalmology, you probably do it along with something else.
I like your comment that you said how collaborative being an ocular pathologist, ophthalmic pathologist is. I remember Doug Cameron was one of my favorite people of senior mentorship, and I just always appreciated how when I had a condition that needed a pathologist's eyes, or even grand rounds and we hadn't figured out a case yet, the insight, the perspective, kind of like a really good genetics team that we enjoy here too, that just, it brings alive that granular disease state. And I just would appreciate how you do that in terms of the ophthalmologists you work with, that not just their insight into the clinical situation helping your understanding of the disease, but also your understanding really making it a rewarding thing to care for patients on their end. So I appreciate that aspect of it and know that you continue to do that in a rich way. I have to ask though, when's the last time you took tissue off your own patient and looked at it versus receiving it from other people?
Not very often, actually. I mean, I do largely cataract surgery in my surgical practice, but I'll do, small eyelid lesions and things. It's funny, though, oftentimes just because of the way, things essentially get assigned or triaged in pathology, it might not make it to me because I'm often the referral point. So, if a biopsy is done somewhere other than the University of Minnesota, it will get sent to their hospital pathology department first and then come to me. So for simple things, they just get done before they get to me if they're not necessarily on the eyeball. So I don't read out my own things, which I actually think is good, because one of the things that you'll often do as a pathologist is you look at the slide before you look at the history, because you maybe don't want to be pre-biased by the clinical impression.
Kind of like radiology.
Yeah.
That's so interesting.
And how much time do your program, and here too, we at Mayo, our residents have a ophthalmic pathology portion of their training, but at the University of Minnesota, what structure do you have there in terms of how much time a resident has with you during their rotations?
Yeah, we're kind of revamping things right now, actually, and the plan is that they'll be with me 1 day a week for a half day, for one of their rotations,
blocks,
which is 10 or 12 weeks.
Yeah.
And that's nice. I typically have PGY2 learners.
That's great.
And I love that. They're perfect for pathology because you're getting to see the eye and the anatomy in a different way. And so it allows them, just a different view to try and understand something. And in some ways, you're getting to see it in a more direct way, like looking at structures of the angle, seeing them on the pathology and then correlating that with the gonioscopy. And you can also see the disease process. You can see the inflammation in the uveitis. You can see the ulceration, that divot in the cornea, and you can see the organisms there. So it really, allows them to actually visualize what's happening in the patient's eye.
Yeah, I think Path is actually very accessible learning wise in those early stages. I remember like feeling like, okay, I can read the Path book, the BCSC, and actually understand it. Whereas some of the like the Retina book or the Cornea book, no way. It's way too dense, but the Path book seemed very accessible. That's great. One thing our residents do that I love is that they get to do the gross sections and then see the specimens once they're plated on the slides. And so they can really see kind of the full circle of a specimen. They're not necessarily in the case where it's collected, but sometimes even just doing the sectioning and getting to see the tissue, I think it makes it more real. And then you get to see it on a slide and then see it on the, going from the macroscopic to the microscopic level. I really like that.
So you're obviously, teaching residents is, a core part of your role at the University of Minnesota, but also even teaching people in practice. And many of our audience members are in ophthalmic practices. And probably if there's a meaningful lesion intraocularly, they're going to be referring or getting help for if they're not in a subspecialty situation. But commonly, people might take off conj lesions or lid lesions that they feel comfortable doing. So as an ophthalmic pathologist, what tips or education or warning signs, or where are those moments where you reach out to the comprehensive ophthalmologist that took off a lid lesion and thought, I have an advice for you or a tip for you, or in the future, what would you suggest for listeners that might dabble in lid lesion or lesion removal from your perspective?
Conj lid, that's a good question. I want to know.
Yeah. Well, and I think as you're talking about like the relationship that you have with your colleagues, with people who submit specimens, that is an advantage I feel like I have as an ophthalmology trained pathologist, because then I also have, I know the people who are sending me specimens personally, and that lowers the barrier to have them be able to contact me or me be able to contact them. Because my main advice is just, if you have any question, just contact the pathologist. Call me up, talk to me, text me, email me, because what you want to make sure you do is handle the specimen correctly to get the information that you want.
Okay.
We're dealing with such tiny amounts of tissue, and sometimes you only get one shot at the lesion, and probably the most common, kind of mishandling, or not really, or missubmitting maybe of a specimen, is if there's a question of cicatricial pemphigoid. That has to evaluate for that, we have to do direct immunofluorescence, and direct immunofluorescence can only be done on fresh tissue or tissue in a specific medium. So if you just cut that out and then put it in formalin, I can tell you, well, it's not cancer and maybe it's not sarcoid, but I can't give you the yes or no. Is it OCP? And so, that's one of those situations where sometimes I'm like, oh, I kind of wish you would have just called me and said, hey, I'm looking for this specific thing. I want to make sure I submit it the right way.
I think that's a really good tip, and having that communication is key. I'm always calling pathology, like, how should I send this? What do you, this is what it looks like clinically. What should I do? That's great. I'd love to hear too about your whole approach and mentality teaching cataract surgery. Totally different than pathology, but harrowing nonetheless. And so I'd love to just hear about how you teach residents and what it's like teaching cataract surgery.
It's a ton of fun.
Yeah.
And again, more recently I've had more of like the senior residents, but I'm trying to get back into some of the PGY2, PGY3 learning, because there is nothing more fun than being there for a resident's like first time in the eye.
Yeah.
I mean, they're just thrilled by it. And it kind of like rejuvenates your own, after you've done however many thousands of cataract surgeries, it helps you remember what it felt like for that to be the coolest thing you've ever done,
Yeah.
And really, I think like most surgical teaching, it's you start outside the OR, right? So I always make sure, have you done the reading you need to do? Have you been in the wet lab? Have you been on the simulator? They have to do all their preparation before we can be in there in the real patient. And then, early on especially, it's it's really cool for them to do very small things. So it's starting with the paracentesis. I was taught cataract surgery with kind of like a back-end method. So the first thing I did was insert the lens.
Yeah.
So that's what I have early residents do, and then remove viscoelastic, and then remove cortex, and you kind of work your way that way. And then when I'm working with senior residents, I want to know what their goals are, because they're about to go out there, and I want to make sure that the thing we're working on that day is the thing that they feel like they need to make better, you know, so that I've talked to them, and then we have kind of like a little goal for each case.
I think that's really actually a great point that a lot of people don't consider with surgical teaching. And even I do a ton of cases with the residents, but to actually stop and say, what is your goal for this case? Do you want to do the whole thing start to finish, or do you just want to try a different technique? Or do you what are you really trying to get out of it? I think that's really important to recognize, because it not only helps the resident get what they want, but then it helps you support the resident too. Because otherwise, sometimes I'm just there kind of sitting watching them work, but maybe they're not getting out of it exactly what they had intended. That's a great tip. Good surgical teaching tip. Love it.
So, I mean, you both are involved in, we're talking about teaching residents, and we all do that. And certainly, Andrea, your role in leading our residency here. But how often in cataract surgery do you think are rubrics used? Rubrics being a tool that breaks down each step with grading and feedback. I think so often I finish a case with a resident, and it'll be very easy to say, really nice job, I liked how this is, but you don't actually go back to say, all right, remember, let's talk about the conj incision only. How was that? How was the Tenon's handling? How was your cautery? Tips about hooking the muscle, or whatever it might be in the procedure. And I know there are cataract rubric. There's one for pediatric cataracts that I use. I have one for strabismus. But do you guys find that valuable or commonly used in residency programs? Or any sort of standard rubric of evaluating each stage of their cases, or not so much?
I mean, I think as someone, especially because when I'm at the VA and I have an intermittent appointment there, so I'm there regularly, but I'm not always with the same resident every time necessarily. So I'm seeing the resident at different points throughout the year. And so I don't, they don't have a formal rubric that they show me, but I do like to touch base with them at first and be like, okay, tell me how many cases what's your number right now? And again, which step do you feel like, you have the most challenge with, and what do you feel like you're smooth at now? So, I don't have maybe a formal rubric, but I do think having, I think it's helpful for residents and helpful for a program to have kind of an overarching, goal or benchmark where people should be at certain points.
And I like the
be able to help
intentionality.
get them there.
Yep.
Yeah.
I agree. I like the intentionality of not just thinking about what you'd like them to do, but kind of stopping to say, where are you in that journey? If you already know beautifully how to divide and conquer, well, what are we working on now to complement your skill sets? But wonderful. I'd love to transition to your next hat. We talked about all the hats you wear, the plates you spin, but that is, you are the current president of the Minnesota Academy of Eye Physicians and Surgeons. Share a little bit about what drew you into our state society efforts and leadership.
Well, first of all, I really love the Minnesota Academy of Eye Physicians and Surgeons. So when I first moved to Minnesota, I'm, brand new out of training, out of fellowship, and it was a place where I could go to these meetings, and everyone was so welcoming and just excited to have another person in town, and excited to meet you and learn about you. And I think in the state of Minnesota, we have a fabulous and supportive community of ophthalmologists, and our colleagues here are just wonderful. And so as an organization, we've got fabulous members and do great things. We have a nice YO program, and we support CME for our members. We have our kind of social event, our gala coming up, which is a ton of fun. So it's, just a multifaceted way that we try and meet the needs of our members. And when I got asked to be on our executive committee, which is sort of the leadership patch, so you start as secretary, and then you're treasurer, and then you're president-elect, and then you're president, and then you're past president. So you're sort of on the executive committee for 5 years. To be honest, I didn't really know what I was getting into. I thought, oh yeah, I like this organization. I want to help. I want to do this.
Yeah.
And then you kind of learn more about the job as you go. But it's been great. It's been a very, very busy and, in some ways challenging year. But I have learned a ton, and now just appreciate the value of a state society even more.
Yeah, I think Dr. Bothan and all three of us have been part of MAPES, formerly MAO, for a long time. I was a resident board member, and it's such a strong state society with a really rich history. I learned right away, like monthly meetings, people who care about it deeply, like a long time devoted executive director. I mean, it's a really strong state society. So I think it's so important that you've taken the leadership role there, and it makes sense that you just fall in love with this group and everything that it's giving to the community. But we were just chatting how much state societies and the goals and the needs have changed over the years. It's completely different culturally than it was 20 years ago, when it was maybe kind of like a more old boys club vibe, and then even from 5 years ago, pre-COVID. Kind of take us through what you've seen transition-wise in state societies, and what you see as president as the role of state societies in ophthalmology.
Yeah, so I think our role is multifaceted, and the needs are probably different in each state, depending on your academic institutions and what other resources that your members have. And meeting the needs of the membership really has changed. Traditionally, MAPES has had sort of monthly CME meetings, and they've been at a country club with a social hour, and then a dinner, and then an hour CME on a Friday evening. And there's really fun parts about that. But for me, I'm a mom of a 2-year-old and a 5-year-old, and very busy, and it's sometimes really hard for me to tell my husband, like, well, actually on this Friday night, I'm going to leave you home with our 2 kids, and I'm going to go spend 3 hours, like, hobnobbing with my colleagues.
Yeah.
I love that.
Yeah.
But sometimes that's maybe a hard sell for my husband. And so it's how can we, still have some of that aspect and those collegial things, but be flexible for our members, make sure we're reaching people at all stages of their career and their home life and family life. And so we've made some changes over the years, as I've been on the executive committee to try and do some of that.
Mm-hmm. It's such a good point, too. I really value the dinners and the networking, especially as a resident, even getting to know all of these amazing people in practice in Minnesota, in private practice and at the university. It's great. And I tell our residents how important it is for networking for them. And I loved it as a resident. But you're absolutely right. In this phase of life, when you've worked all week and now you have little kids, to say, I'm going to not have this Friday night at home, it's really challenging. And then I think as we've transitioned to having broader acceptance of virtual things, since COVID, that kind of changes. Like, should we be all in person? Should we have hybrid options? I can imagine that it's very challenging to even figure out what the needs are of the whole group of ophthalmologists in all kinds of different stages of life. Yeah. Seems like hard.
And it's, we're lucky to have so many more tools now, right? Like, you can learn via Zoom, and people get their CME now in so many ways. You don't have to physically be at a meeting to get your CME.
Right.
So if people don't have that motivation to come and get together, can we offer it in different ways? What can our society do to make sure that people are able to meet their CME needs, but do it in the way where they still want to do it through us?
Mm-hmm.
Yeah. One of the critical roles of state societies is to continue to have a voice in the advocacy, and as a whole, the more voices you have at the table, more perspectives within our ophthalmology community, but then even beyond, the more I'd say valuable and supportive in terms of the goals of healthcare and quality of life and patient safety. Share, just because state by state there are varying legislative journeys that states go through, and whether it's firecracker safety or medication management or surgical practices, the roles here at Mayo, we really feel that one of the critical parts in developing care is teamwork. And we have a wonderful optometry team aspect to our care models. And yet state by state, each state's a little different in how those relationships are carved out and handled. But share just from a broad perspective from the importance of advocacy for the voices to be at the table in the continued moving forward, shaping, but also protecting the practice of eye care for people. Share, but just your perspective as you've been through that yourself, even this year. Why you'd advise people to be involved in their academy?
Yeah. Advocacy is such a big part of what we do, and it's so important. And it's important not only for us in our profession, but also for our patients, right? Like that's what it always comes back around to, is how are we getting people the best possible eye care? And I think the thing I have really learned in this last year, spending a lot of time in St. Paul, is that you have to be there, right? Otherwise, decisions are getting made about you without you or your input, and things will get said that are, wildly untrue. And if you're not there to counter that and to correct, then no one is, and things, will happen, and there can be unsafe legislative moves in the state. So it's just so important to really be there and to have that voice, and to know that if you don't do it, maybe no one will. And so I know so many of our members, as we are working through this legislative session in Minnesota, I'm sending out emails like, please contact your legislators about this issue or about this issue. And I just say, if you're in a state and someone's asking you, just send the letter. It's small things that make a difference, but you kind of need every ophthalmologist who's able and willing to do the part that they can. And we all have really busy lives and really busy practices. So it's definitely different amounts of dedication that people can give. But every little thing that people do really does make a difference.
Wow. Well, Dr. Maltry, we are so lucky to have you at the helm of our state society and leading the next generation for cataract surgery and ophthalmic pathology education. Thank you so much. And thanks for being here with us today.
Yeah, thank you. I really enjoyed it.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more